Okay, well, as everybody joins on, we are just going to go ahead and get started. If you haven't taken a minute to put your name and contact information into the chat, please take a minute to do that. We welcome you to our ECHO session today. Just to remind you, we are recording that. It will be on our Canvas page as well as our YouTube page so that you can go back and review this at a later date if you need to. We use it also for just educational quality improvement process. Participation is a great way to be involved in ECHO. So if you are okay and you want to turn your camera on, it really helps just build that community of practice, know who's on our call, who we can reach out to. And then if you've never done a case narrative or a case discussion and you have a case that you want to share with your colleagues, learn some information, please consider sending one in and doing that. Today, we're going to do our case presentation or our case narrative in a little different format. So throughout the session, think about a kid that you guys may be struggling with, or as we learn more about apraxia that might have some of those concerns, or you're wondering about it, and we're going to be breaking into small groups to just discuss, have an open discussion about cases. You can feel free to put those kid into the chat. We're just going to ask you to always think about the child's age, any relevant concerns or medical diagnoses, any questions that you have for our group, and then anything that you've tried. So, but as you're doing that, just always remember to protect individual privacy. So really trying to avoid first or last names, coworkers, where they live, where they shop, anything that we can identify those with. If you've not taken a minute, please rename your profile with your name, where you work, or your discipline. Once again, it just really helps us understand who else is on the call so that I could, if you say something or you share something, I'm able to, as a participant, reach out to you as well. And then Zoom, we've all been on it enough times. We probably all know how to raise our hand or make comments in the chat. But this slide just goes over that and does a review. Again, thank you all for pre-registering. The handouts were sent out with today's email, but we have some great sessions that are also coming up. So take a minute and register for the ECHO sessions. The way that we get credit for attendance is completing those surveys. Those surveys become very critical in keeping these sessions free of charge. So please take a minute to complete those surveys, as well as after they get completed, we send out the certificate of attendance once a month with that. Canvas, if you have not accessed the Canvas page, that's where we put all the recordings, any session handouts, any information that we have from today's session on our Canvas page. So if you've not done that, Kurt, you can reach out to Kurt Phillips or Early Echo, and we'll get you started. And I see that comment that you can hear someone talking in the background. I apologize. I am in the office today, and I have a coworker who's really awfully loud. So once again, the case studies today, we're going to do it a little bit differently. So really think about some of those kids that you might be struggling with, or you just want some more information about. REDCap is where our surveys come. Sometimes those come to your junk email or your spam, so always check that. Those get sent out today, as well as then weekly until our next session. I'm really excited today to have Paige Mon join us to talk to us about apraxia with young children. She just brings a wealth of information and knowledge. She is a speech pathologist. She's worked in the up to 3 early intervention here in Northern Utah, as well as at hospitals, and I love hearing her and talking about a lot of different things. So I'm so lucky, we're all lucky that she is joining us today. Again, if you haven't followed us on Instagram or Facebook, go ahead, take a minute to do that. We always try to share resources, information about our sessions, and anything relevant to ECHO. So with that, I'm going to stop sharing and turn the time over to Paige to get us going.
Okay. Can you guys all hear me now? Okay. I guess I'll nod.
Yes.
Okay. And now can you see my screen?
Yes, we can.
Okay, great. So I'm just going to do kind of a quick overview of childhood apraxia of speech. Most of the information that I'm going to be presenting on is actually available online. There's a lot of great resources on ASHA and a few different websites that have good information about childhood apraxia of speech. The one that I used quite a bit is the Mayo Clinic. There is a speech language pathologist. Now, why am I blanking on her name? But she is at the Mayo Clinic. It'll come to me in a minute. So some of the videos in here are from her, and a lot of the information is coming from her presentation. So let me just, Janelle kind of already told you about my background. I currently work for Ogden School District. I previously worked with Janelle at Up to 3. I was at Utah State for my first 3 years after graduating, pretty much working in early intervention. Some of it was at Sound Beginnings preschool. And then I went to work for Primary Children's Rehab, and I was there for 3 years. And so I got a lot of experience seeing children that look like they have apraxia, because we tended to get more of those more severe children. And as you'll see, kind of apraxia does tend to be one of the more severe speech sound disorders that we see. So, and let's see if there's anything else I want to say. Yeah, I graduated from Utah State in 2015. And before that, I did work as an assistant speech pathologist in the public schools in Texas. I have no disclosures at this time. Nobody's paying me to promote any product or anything. Okay, so here's what I'd like to go over during the presentation today. I would like to, for you guys to understand childhood apraxia of speech, in particular, how it compares to other communication disorders, and in particular, other speech disorders. And we'll discuss kind of what that means in just a minute for those of you that aren't speech pathologists. And I actually saw there are several of you that are, so you might have some good input on children that you've seen that have signs and symptoms of childhood apraxia of speech. And you'll often hear me refer to it as CAS. So that's childhood apraxia of speech. And sometimes I'll call it apraxia, though apraxia does exist as an adult disorder that's usually acquired from a stroke or a brain injury or something along those lines. But childhood apraxia of speech is usually a developmental disorder. Sometimes it's acquired, but just kind of, I'll pretty much refer to it as CAS most of the time today. I'd like to define childhood apraxia of speech and help you guys understand common characteristics, learn about general treatment methods for childhood apraxia of speech. I'm not going to spend a lot of time on that, and then we'll just discuss the importance of early intervention for childhood apraxia of speech. So for those of you that are not speech language pathologists, I just kind of want to review, and you probably are all very familiar with this too, but the difference between language and speech disorders. So language disorders are kind of how we understand words and sentences, and so there's receptive language difficulties and expressive language difficulties. And receptive language difficulties are when children have difficulty understanding what is being said to them. So the sentences don't make sense to them. They don't know the vocabulary. They just don't have the language yet to understand. And then expressive language disorders are when they have trouble sharing their ideas, thoughts, or feelings with others. Today, we're not going to be spending much time talking about language disorders because childhood apraxia of speech is a speech disorder. And so speech disorders are when people have difficulty producing the sounds of speech. And it's really one of the most common things that speech language pathologists treat. But also within the category of speech, there's stuttering and voice difficulties. But today we're predominantly going to be talking about difficulty with speech sounds. So then can you guys all see all of this chart that's here?
Yes.
Okay. Just on mine, I can, like, you're kind of in the little window of pictures is on my side and I can't see all of it, but I will just kind of discuss here how there's a lot of different types of speech sound disorders. These are all different things that can affect how a child is able to produce the sounds that are necessary for speech. And then you can see that it's divided from functional disorders and then organic disorders, things that are developmental or acquired. Functional are ones where it's just like, we don't really know why they're happening, but they're just, children are having trouble producing speech sounds. Phonology is when children don't quite understand what sounds are supposed to go in what words, and so they'll kind of make consistent errors. And we're going to talk more about that in a little bit, just as a comparison to childhood apraxia of speech. But childhood apraxia of speech, you can see here, is under a motor or neurological disorder down below where it says planning. So it says apraxia there. And so apraxia is a planning, and I really want to highlight that today. It's a problem of planning. So kind of getting the brain to decide what it needs to do to tell the muscles in the mouth how to execute the sound. And so you'll see there that dysarthria is a problem of execution, which means that once it gets to where it needs to, the message from the brain gets to where it needs to go, the mouth is for some reason not able to execute what that plan is. But apraxia is a problem of planning. And so I just want to kind of give you guys this overall structure of how apraxia compares to some of the other speech sound disorders before I move on. And then you'll see there's structural, which is children with cleft palate. So that's something is going on with their craniofacial features that is not allowing them to produce sounds correctly or intelligibly. There could also be structural deficits due to trauma or surgeries, and those things would be structural problems that are causing difficulties in speech sound production. And then the other one listed there is hearing loss. So if a child is not getting good access to sound, they're not sure what sounds need to be made, and they don't get that auditory feedback to figure out how to produce the sounds correctly in their mouths. So kind of that's an overview of the differences of speech disorders and where the problem can kind of come from. And this chart was taken from ASHA, and I thought it was pretty useful, so I wanted to include it. So let's get right into what is childhood apraxia of speech. So it is an uncommon speech disorder. We don't see it all that often. It's not, the most common thing we see. But the problem is, the difficulty is producing accurate planning for accurate movements for speech production. So when we think of other types of speech disorders, it's, the ability to actually make the individual sounds. But in childhood apraxia of speech, it's the difficulty of moving your lips or moving your lips or your tongue to do the sound accurately. And so it's a problem where you'll see in the second bullet here, the brain struggles to develop the plan for the speech movements. There's no muscle weakness, and that's another important thing to keep in mind. That would be more like dysarthria, where there's some kind of muscle weakness that's happening. Those children will usually present with very low tone. You can kind of see it. Their lips are not strong. Their tongues are kind of weak. And that is different from childhood apraxia of speech. Childhood apraxia of speech, usually children have intact strength, but what they're struggling with is producing that movement from one sound to the next. So it results in vowel and consonant distortions. They're not getting their articulators to the place at the right time for their sounds to sound correct. And then they also present with errors in prosody, which is the pitch, intonation, and rate. So they'll just sound a little bit different. And we're going to get to watch some videos in a little bit that hopefully will kind of really solidify what I'm describing here. So it's a movement problem. It's a planning problem, planning on how to get those articulators where they need to go. There's no weakness. and then and it results in distortions of the sounds and differences in how they produce pitch and intonation and rate. And also another thing I added down here at the bottom is that it's a label for a speech sound disorder. It's not a medical diagnosis, which I think is a frequent misunderstanding. So just to know that it's not, it's just a way that we describe the presentation of a speech sound disorder. Okay, so I thought that it would be good to just kind of look at the complexity of what we're doing when we're actually speaking, and the different things that we need to kind of come together at the right time in order for us to produce intelligible speech. So, and when you think about it, it's pretty amazing that children are able to learn this as easily as they typically do, because we have to get our respiration, so that's our lungs, get the air that we need to support our breath that needs to then come through our vocal cords to produce phonation. So that's our sound source. When we talk, we feel that vibration in our throat. That's where the sound is coming from. And then resonance is how the sound resonates through our oral cavity, through our mouth, through our nose. And we have different ways of kind of moving our mouths to change that resonance, and the way that the sound kind of vibrates in our oral cavities. And then articulation is what we do with our tongues, our teeth, and our lips to constrict the airflow. So in order to produce an S, we lift our tongue up behind our teeth and blow air. So you're constricting it, which is what creates what we understand as the S sound. And same thing with P, we constrict the airflow by closing our lips and then releasing that air. So those are kind of all the things that we have to do in order to produce intelligible speech. And then again, like I said, our brains have to plan and direct the muscles to reach the right place at the right time in order to achieve speech sound accuracy, not just for individual sounds, but putting them together in a way that makes the word become intelligible. So there's a lot of different parameters that our brains are kind of planning ahead of time before we even make the movement. So we have to kind of plan how much muscle tension we need for each of those sounds. We have to plan the speed of the production, the speed of the movement from one place of articulation to the next. We have to control the force, how strongly we're pushing out our air. And then the range of motion, how wide are we going to open our mouth? How far are we going to move our tongue forward or backward or up or down? So we kind of have to understand that, and then which direction we're going to move from one place to another. So there's a lot of complexity here, and these children with childhood apraxia of speech really struggle to kind of put all those pieces together and create a good plan to get the message to those muscles that are going to help us make those sounds. And then, so I thought I would just kind of show you guys some early signs of childhood apraxia of speech. And then at the bottom here, I mentioned that these are not necessarily helpful in diagnosing childhood apraxia of speech. These might be the first things that you notice, but at such an early age, like I say here, from between 18 to 24 months, we're not going to be able to say, oh, that's apraxia quite yet, because usually they're not saying a lot of words, right? So that's what it says here. They have a delayed onset of their first words, a limited number of spoken words, and a limited phonemic inventory. They're not making a lot of different speech sounds. They have very few consonants, maybe a lot of just really neutral vowels, a lot of rather than e or oo, those more like kind of tighter speech sounds. So the only reason I bring this up is just, as we are looking at children in those early 18 to 24 months, just start noticing, wow, they're just not making a lot of different sounds, or they don't have a lot of words yet. And like I said, it's not necessarily that we're going to be able to say, ding, ding, that's apraxia, but it's going to kind of, kind of keep us watchful of what's going to develop next. And then again, this is another slide where it's talking about just things that we see in most children with speech and language disorders. So again, these are not specific to childhood apraxia of speech, but they are things to kind of keep watchful of. And I think a lot of you are in early intervention, and so you're already doing this all the time. But just kind of a reminder, these are things that a child with childhood apraxia of speech might present with, but they would also potentially could have some other speech or language disorder. So they babble less between the ages of 7 to 12 months. They're not, able to yet start practicing those speech sounds like babies typically do. They start speaking their first words late. They use a limited number of consonants and vowels. I already said that. And then they frequently omit sounds. So, they might shorten a word from 2 syllables to 1, or they might leave out the first consonant in a sound or the last consonant in a sound. Again, that can present in other speech disorders, but just something to look for. And then their speech is difficult to understand. Now we're going to get into really the meat of what childhood apraxia actually looks like. And so these are the, there's 2 slides here. I'm going to just show you. There's a couple of things. And so there's quite a few things to look for. And these are the characteristics that are unique to childhood apraxia of speech. And I'll kind of go through them, and then we're going to watch some videos. And hopefully some of them, you'll be able to point them out and see them as I show you the videos. So the first one listed here is articulatory groping. So that's kind of like you see a child that's really trying to get there, and they're moving their mouth or their lips like they're thinking about how to get to the right place. And so it's kind of described as trial and error behavior. They're like reaching for it and really struggling to find that right placement. So when you see a child that's kind of, before they even start, they're kind of like, moving their mouth or the lips a little bit, that could be an indicator of childhood apraxia of speech. They're going to have consonant distortion. So that's inaccurate movements causing a distortion of the speech sound. This is distinct from a phonological disorder, because usually in a phonological disorder, a child might substitute a T for a K, but the T sounds really good. It doesn't sound slushy or distorted in any way. They're making a nice T sound. They're just saying tat instead of cat. So with a childhood apraxia of speech, that T is going to sound kind of, that's not going to sound quite like a crisp T. And you'll see some of that in the videos that I'm going to show you. Another thing that is unique to childhood apraxia of speech is clumsy movements from one speech sound to another. So they might just kind of sound awkward, producing the different syllables or consonants in a word. So, and you'll see it again. You'll see it in the videos, but it's not just like a quick, easy movement. There's some it breaks apart, or the sounds just don't sound quite right or flow together. And then vowel distortions are one of the most common things that we see in childhood apraxia of speech, and even in children with milder versions of it. So some of the other things you'll see them in more severe children, but some children that have kind of mild childhood apraxia of speech frequently will still present with these vowel distortions. And in my experience, what I see a lot of time is neutralization of the vowel. So like I said earlier, there are vowels that have, require more tension in your cheeks or your lips to produce them correctly, like an E. A vowel distortion, I feel like a lot of times they'll just kind of neutralize those vowels. So instead of E, it might be more like and so that's just kind of what I've seen. But it's a very common characteristic of childhood apraxia of speech. Then you'll see some voicing errors. And so when we make different sounds, a P and a B in these examples like pat and bat, we do the exact same thing with our lips and our mouths. The difference is when we turn our voices on or off. So if you do bat, you start with your voice on because the B has that voicing. Pat, the P doesn't. It's kind of more like a P. And so children that have childhood apraxia of speech struggle with the timing of when to turn their voice on. And so you'll see things like they might be trying to say pat, but they say bat because the timing works, or vice versa. They just can't get the timing right to make it sound accurate. Another thing that we'll see is schwa insertion. And so a schwa is that neutral vowel So they'll kind of stick those into words randomly. So the first example is if the word was pat, they would say pat, pata, or put it in the middle, like in this word basket, basakit. So they kind of just are sticking these extra sounds in there that don't belong in the word because they're not quite getting all of the pieces together. And syllable segmentation is another one that I see quite frequently in children with childhood apraxia of speech. They might be trying to say a word like baby, but they would say baby. So they know how to do the different parts, but just blending them together isn't happening smoothly like it should. And then also very common, a slower than typical rate of speech. Because they are working so deliberately to be able to produce intelligible speech, it comes out very slowly. And so these things, like I said, are very unique to childhood apraxia of speech. And if you're not a speech therapist, and even if you are a speech therapist, for me, when I started out, I kind of, struggled to know, is that really apraxia or what is apraxia? And I think even with experience, you still kind of get a little like, oh, what is it? But kind of thinking about this list and coming back to it, and you can find this exact list almost on ASHA and on the Mayo Clinic's website. So these are kind of just those really key things to look for. And I think when you kind of start to compare, what does that child look like that has these errors as compared to a child that has typical phonological disorders, it kind of starts to make a little more sense. And hopefully when we watch some of these videos, that'll come together for you guys too. Okay, so here are a couple of children that have severe childhood apraxia of speech. And I didn't clip these videos down a ton, so I just kind of want to check the time. Okay, so they're probably about a couple of minutes long, and I've got a few of them here. So feel free to jump in, Janelle, if you think I'm running out of time and spending too much time on these videos.
Okay, you are good on time so far.
Okay, great. So in these videos, you're going to look for some of those things: articulatory groping, inconsistent errors, which now that I think about, I didn't have up above, did I? Well, that's another very common one. I'm not sure why I missed it, but I'm glad that it's here, because so they might try the same word and it comes out different ways from one attempt to the next. That is another very key classic sign of childhood apraxia of speech. And then sound distortions. So like I said, they're not just substituting a crisp, clear T for another sound. That T is just not going to sound right. So let's look at it and see if you guys notice kind of some of those things that we talked about.
Good job. Bye. Up.
Up.
Moo. Dad.
Dad.
Home. Out. Out.
Out.
Knee.
Me.
No.
No.
Hi.
I.
Use your breath.
Hi.
Good. Mom.
Mom.
Me.
Me.
My.
Bye.
Hi, Mom.
Hi, Mom.
My knee.
Mommy.
Oh, no.
No. Oh no.
Good job.
O E O F E A A A
Very good. And how old are you?
A.
Good job.
In this next clip, you will see a child who exhibits a number of characteristics of childhood apraxia, including groping for sound positions and off-target movements that distort sounds. Notice how he is inconsistent over repeated tries at the same word. Toward the end of the clip, notice how he does better if he's looking at the clinician's face.
Pie. Popeye. Two. Day. Dad. Very good. No. No.
Okay, so I don't know if anybody has any, you can in the text box, if there's anything that you in particular that you noticed, you can type it in there. I'll just kind of start naming some of the things that I saw, there was that segmentation. So when the little boy said, "Hi, Mom," it's more, "Hi, Mom." There were the first child had some distortions, trying to say up. He kind of got it, but the timing wasn't quite right. And the P was a little bit kind of messy. Yeah, groping. And that last child especially is doing some real groping. Like he takes a minute before he even starts attempting to make those sounds. There were a lot of vowel distortions, the child trying to count. At the beginning, they sounded a little bit more like the numbers, but then toward the end, it was just a lot of so that those vowels aren't quite getting there where they need to be to sound accurate. So I will, oops, I did not mean to start that again. But let me go on to the next page here. And so this is an example of moderate childhood apraxia speech. So this child is talking in longer utterances. So it's not just single words or 2 words or 2 syllables. He's kind of getting to where he's able to put more stuff together, but it's very effortful and his rate is very slow. So this is kind of a nice example of once a child is starting to say more stuff and put more stuff together, it doesn't sound the way that it typically should for a child who just has like a articulation or a phonological disorder. This is going to sound like he's working much harder.
I sit on my bed.
I sit on my bed.
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 I need my Ben 10.
I need my Ben 10.
Oh, I heard all those good sounds. I won't fight.
I won't write.
Good job. Look at me over here. I will have fun.
I will have fun.
Let's try that again. Watch Edie.
I will.
Watch Edie. I will have fun.
I will have fun.
How about this one? I write with my pen.
I write with my pen.
Okay, so I just was looking at the chat here.
On my bed.
I sit on.
Okay, so for this child, you're seeing those distortions. His sounds are not quite right, very effortful, and you can see him looking at her for a lot of cueing so that he can figure out what he needs to do to put the sounds together. So I think that's kind of just a nice example of where it's starting to be more intelligible, but he's still kind of missing the mark on some of the sounds. And there was a voicing error. It was a V for an F. I can't remember what it was now. Fun. No, it wasn't fun. It was a different one. But if it would be like saying fun instead of fun. So there were some of those kind of and vowel distortions as well. Okay, now as a contrast, I want to show you what a child with dysarthria looks like. So again, I mentioned earlier, dysarthria is a motor speech disorder characterized by weakness of the tongue, face, and lips. So these children are going to kind of have lower tone, and it's not a planning problem. It's a problem of just have enough breath support and enough muscle tone in the face to be able to produce sounds accurately. So just as kind of a contrast to thinking about what's more of a planning problem, and this is more of an execution problem.
This first example of dysarthria is characterized by decreased breathing support and distortion of sounds that likely reflect weakness. He also has some spasticity that we hear as strain in his voice and his slow rate of speech. His comprehension and intelligence, however, are quite good.
I live in a blue house. They have a big desk at school. The team has a broken leg. Don't go too near to the water.
Okay, so for me, when I watch that, the difference I really see between him and the other children are when he does have distortions, it's not the movement that's the trouble, it's the strength behind it. So that he can't like pop that T because he doesn't have a good strength in his tongue. Whereas with the other child, it's getting the tongue in the right spot at the right time to make a good T. And if anybody has any questions about that, just kind of, yeah, so more of slurred speech, exactly. That's kind of how I would describe it too. Breathy, slurred, they're just not getting that strength behind the sounds. Okay, now the next one I have is a phonological disorder. And this is pretty important to like as a contrast because I think that's where even as a speech therapist, we kind of struggle to know, well, this is a pretty severe phonological disorder, but is it apraxia of speech? And for me, when I watch this child talking, it's very clear that she has the ability to really produce the sounds nicely. Her prosody sounds very good. Her pitch and intonation are matching what we would expect a child of her age to do. She kind of sounds, apart from being hard to understand, the kind of the flow of her speech sounds pretty typical. It's not disjointed, segmented, and super slow. So I will play it for you, and you're going to hear some. No, did you have a question?
There's a question in the chat, just asking about before we get to the next video. These kids that you just talked about with the question said, would these kids have issues with feeding early on, just maybe because of the lack of respiratory support or whatever? I'm guessing that's Nancy's question.
Yeah. So I would say probably a child with dysarthria is more likely to have feeding disorders than a child with apraxia of speech, but they both can because of, if a child has oral apraxia, which is not like oral non-speech apraxia. And I'm going to talk about that just a little bit in a minute, but exactly, you're right. Like a child that has that weakness is for sure more likely to have feeding disorders, but you can also see feeding disorders in a child with apraxia just because of the planning and timing and getting all of that right to appropriately chew, swallow, with accurate timing. So you can see it in both, but weakness for sure is going to make that even more difficult. So good question. All right, so yeah, I'll come back to this video here. This is phonological disorder. It's a little girl. She's got some pretty typical errors that she's producing. She's going to substitute T for K a few times. That kind of typical, like the kid saying tat instead of cat. My daughter used to say tozy instead of cozy. She had that error. But it was just a very typical thing that she grew out of. Some kids will stay with those errors for longer, and we end up treating them as speech language pathologists. But this girl's just going to sound kind of more typical. And another thing that she does is she's already starting to self-correct. So she's realizing what she's doing wrong and starting to fix it.
Gap. Night. Boom. Yeah, bit too. Bit boon and little boon and bit hot and little hot.
The spoon's a big one, but what's this one?
Cup.
A cup, but what did you say? A big
boon and a little boon and a bit hot and a big and a little fork.
Are these forks or knife? What's that?
Sable.
Okay, who's that?
Monkey. Banana. Tree.
Good. Okay.
Zipper. Zipper.
Okay, say it one time.
Zipper.
Whoa, you're thinking about your sounds.
Fiddle.
Okay.
Duck.
What color?
Yellow.
What's the duck say?
Quack. Quack.
Good job. What's that thing?
Creeper.
A sweeper?
Yeah, we have a little one and a big one. But
Oh.
we just bought a red one.
You just bought a red one?
Yeah, and we did the art on new red one. We good.
You could do what?
We took a date on new one. The new what he not like people. We did the art. We good.
Oh, okay.
Swimming.
She's swimming. Good
I
job.
wanna swim in the outside bowl.
You want to swim in the what?
Outside bowl.
Oh, in the outside.
Okay, So like I said before, her errors are consistent. I mean, well, except for when she's starting to self-correct because she's realizing that she's making those errors, but she's making consistent errors across the board typically. And then especially when she's not thinking about it. And then her rate sounds good. Her flow sounds good. She doesn't look like she's laboring to reach those sounds that she's making. They're not correct sounds, but it's not like she's having, it's not effortful for her, and her rate of speech sounds good. If anybody, I don't see any chat questions about that, but if anybody has anything that you've thought of and noticed or whatever, just feel free to jump in with a chat.
Gap.
Why do I keep doing that? Okay, so this one is a case where a child has both. So he has some typical phonological errors that he's making, some substitutions. And off the bat, I can't think of what they are, but listen for them. And then if you notice any typical substitutions of speech sounds, point them out. And then, so he's got some pretty typical consistent error patterns, but he does have vowel distortions. And then in particular, his rate of speech is slow. So those last two things that I have listed there, vowel distortions and slow rate of speech, are the things that would tip me off. Oh, he has some, typical error patterns, but the way he's moving his mouth doesn't look typical. It looks more like childhood apraxia of speech.
What's this?
A flea.
Good job. What's this?
A phone.
What's the long name for it? Is it a telephone?
Yup.
Can you tell me that?
Telephone.
Good job. This is a
Teacup.
teacup. That's right. It is a teacup.
I have some yuckies in my ear.
You have some yuckies in your ear? What happened?
Doctor, how did I was playing in the swimming pool last night.
You were playing in the swimming pool last night?
Yup, and Daddy hit my foot.
Daddy hit your foot?
No,
What is?
Dalton.
Oh, Dalton. Is that your brother?
yeah.
Yeah, Dalton hit your foot. Well, tell me what you were doing.
Playing on the blue slide.
Oh, playing on the...
Okay, so were there comments? I can't see. Are there not any?
I don't
that's
see
it.
them.
There's not.
Yep.
Okay, so some of the typical error things, he said teacup instead of teacup. He's not getting that K and G. He said fwee for tree. So some of those are just pretty typical things that you might see. But then when he puts it together in a sentence, you see that he's working very hard to get those things, and that his rate is just slower. And then his vowels don't quite sound right either. He's trying to say, I think it was Dalton. He's not getting that all Dalton. He's kind of said data, and that's where she didn't understand that. So his vowel in phone, he was trying really hard to get phone, but he went phone like that. So he's not getting his vowels quite right. So this is a nice example of a child that does present with a little bit of both. Okay. So, all right. Like I said, there are some other, a lot of times children with childhood apraxia of speech are going to present with other things, making it a little bit more complicated to kind of piece out. But so they very often, almost always, are going to have some phonological impairments too, because they're kind of going to be doing some substitutions for sounds that they're just not able to make. And like a typical child would during speech development. They're often going to have a language delay, because if they're not getting that opportunity to make sentences, it's going to take them a little bit longer to figure out how to produce accurate sentences. They might understand, although there are cases where a child might have apraxia of speech and a receptive language disorder. But for sure, expressive language is going to be delayed because they're not quite able to put the sentences together the way they want to. Apraxia of speech can also come along with disorders of cognition, autism spectrum disorder. So it's not like if they have apraxia, that's the thing they have. They can also have other developmental disorders at the same time. They're typically going to have difficulty learning to read. If you're not getting accurate understanding of all your different speech sounds in those early developmental years, then they're going to really struggle when they start to figure out what letters represent what sounds. And then another one that's very common is problems with social language and pragmatics, because they're not getting that good practice and other children are not exactly sure how to interact with them. And they might treat them a little bit differently. And so all of that social feedback that you're typically getting during those developmental years is not happening the way that it would. Does it co-occur with larger motor planning issues, clumsiness? Yes, and that's on my next slide. So good question. For those of you that are OTs and PTs. Let me just finish this slide off here. Usually we don't know the cause of childhood apraxia of speech, but it can be present developmentally or it can be acquired. So we know that it's something going on neurologically. Sometimes we can attribute it to a stroke or a brain injury. Sometimes it's just that's what it is. I think I did read that there is a genetic component that is being identified. I can't tell you specifically what it is, but they're starting to kind of see, and it is something that you might see along a family. So there is a genetic component. Okay, and so on to that question. Hold on, there we go. No, I'm sorry. I don't know why I'm struggling here with turning my pages.
Portions.
Good.
Okay. It's for some reason it didn't want to switch between the slides. Okay, so here's that question. Co-occurring non-speech motor movement. So yes, often children with apraxia are going to show gross and fine motor delays, motor clumsiness, oral apraxia. Like I said earlier, there's such a thing as non-speech oral apraxia. So that's like if you were asking a child to pucker their lips to make a kiss face or to smile or do like click their tongue or something like that, they're not going to be able to do the motor planning necessary to do those things, but those are not speech tasks. Those are just oral motor tasks. So then you might also see feeding difficulties like listed here below. And then limb apraxia. I'm not a PT or an OT, so I don't know a ton about it, but I do know that it's that same kind of planning difficulty. And so a child is going to struggle to get the timing right to move their limbs, their legs, their arms in the way that they want to achieve the movement that they want to achieve. It looks like there's another comment. Oh. Okay, so this comment is about how it's hard in early intervention to distinguish childhood apraxia of speech because the children don't have enough language. Yes, that is exactly right. They don't know how to imitate yet. And so and they might present as behavior difficulties. That's a great thing. I've seen so many kids like that, where they don't have the ability to show that they're trying. And then they might get frustrated and not try. And so then it kind of just starts to look like this bigger problem that's like, well, they're just lazy or, or they're just a behavior kid. And so, yeah, I think I mentioned that on one of my slides at some point, but children will often not have enough language for us to determine whether it's childhood apraxia of speech yet. They're not quite imitating, so that you can't get them to show you a bunch of different target words, so you're not sure what they're trying to do. And so that they do need to kind of be at least at the point where they're consistently imitating and able to sit through a standardized articulation test to really be able to hone in and say, oh yeah, this is apraxia. So which is kind of the next thing I was going to talk about for an assessment for a child like this. You want to do a language sample, just kind of play with them and see how they're communicating in free play or even structured play where you're trying to elicit certain behaviors. Just kind of having that more informal look at what they're doing for communication. A standardized articulation or phonological test is excellent thing to use to kind of see what they're doing with their different speech sounds. Are the errors consistent from one sound to another? What are they looking like in those single words? And that is what she was doing in the video that we looked at just a minute ago. And flipping through those pages was a standardized articulation test, the Goldman-Bristow. Then you want to do a structural functional assessment. So looking at how they're able to use their mouths outside of speech. kind of getting them to show their range of motion with their mouths, their tongues, their lips. With the oral mech exam would be a great thing to kind of look here. Can they stick their tongue out to the side, up and down? Can they plan those things? And that'll help rule out, oh, this is a problem of weakness. They're just weak. You can kind of see that they're not getting quite the range of motion that you want, or the strength behind the tongue movement. But if you can see a kid that has great movement like that, but then they're just not able to achieve it in speech, then we're probably looking at apraxia. That is an option. It's another piece of information that would help us come to the conclusion that it's apraxia. And then a dynamic assessment is kind of, what are they doing if we give them that support? And that's where we're really going to see, oh, they are trying so hard to achieve those sounds that we're asking them to do, and it's just still not coming together. So a lot of times a kid, with a speech sound disorder, like a phonological disorder, they can maybe achieve the sound, and then you can get them to do it. And you see, oh, they're stimulable for that. Where a child with apraxia, you're going to start to see more of that groping. They're reaching for it and trying to achieve the sound and not getting there. And then a motor speech exam. There are some standardized, more formal assessments that now I can't think of the name of the one that's like kind of the most common. But there are some assessments that can kind of look at what they're doing with the speech sounds across different places in words. And that gives us more information too. Oh, they're not just making that same error over and over again. They're just struggling to even try to achieve that word, whether it's a P in the beginning of the word, or a P before an open vowel, or a P before a tight vowel, that they're just, all of those different placements are a struggle for them. So that those are some ways to really get in there and determine the difference between just a standard phonological disorder and apraxia. And I'm serious. I don't know why my computer is not scrolling from one page to the next. Okay, there we go. Here are some different treatment approaches. So when a child has apraxia, a lot of it is going to be motor programming approaches. This top bullet point here, motor programming is really focusing on getting lots and lots of motor practice, just like you would with physical therapy or occupational therapy. You just kind of got to drill those movements over and over again. Frequent intensive practice targets. So tons of repetition of the same words over and over again, so that they build that muscle memory to be able to do that planning to make those sounds. You want to focus on accurate speech movements, really getting the sounds to sound right, not messy and slushy and distorted. And then you're going to give them a lot of external sensory input. We've all done this, like getting right in a kid's face, letting them see it, letting them hear the sound, and then visually cueing them. Oh, it's a T, right? So you're going to just giving lots of feedback for those things, and frequent telling them whether they're right or wrong, and kind of helping them understand when they're achieving the target or not. And then you might also have to do some linguistic approach to it. If a child presents with a phonological disorder and apraxia together, they're going to need a little bit of help understanding what is a T versus a K. So you might kind of target it in that way. Then prosodic facilitation is when you use melody, rhythm, and stress. So it might include tapping it out, using a sing-song voice to kind of help them achieve increased utterance length and longer syllables. And then finally, you might want to use AAC, augmentative and alternative communication. If a child is just really unintelligible, but they have a lot they want to say, and they're able to navigate a device, that's a nice supplementation to help them become more understandable and communicate the things that they want to say. And finally, I just wanted to add how important early intervention is, because childhood apraxia speech is unique. It needs a lot more intensive support and help. It's not something a child is necessarily going to grow out of the way that they would grow out of a phonological disorder. Potentially, some children struggle with that for a longer period of time too. But if we can, and a lot of times these children receive later diagnoses. It does take a while for us to get to a point where we can recognize, oh, yep, these things are movement problems. They're not consistent errors. They're really struggling to coordinate those movements. And so that's when we know that it's apraxia. It does take a little bit longer to come to that conclusion if your SLP is not quite confident in that area, which, like I said, it took me a little while to feel a little more confident about it, and still have children on my caseload where I'm like, oh, that looks like apraxia, but I'm not positive that I want to come out and say it for sure. So, and I think that might be kind of common among other speech therapists too. And then early diagnosis and intervention can really help decrease the risk of long-term persistence of the problem. So if we get in there earlier, we can really make a difference.
One more question, Paige.
Yeah.
In the chat, when is the earliest child can be diagnosed with apraxia?
Yeah, I don't have like an accurate answer for that, but like I said, they need to be able to imitate a variety of words, or you need to be able to see that they're really trying to say these different sounds, and it's all kind of coming out fleshy and not quite there. Their speech sounds don't sound like a T doesn't sound like a crisp, clear T. I would say probably around 2, you might start to be able to, confidently say that. I've worked with a lot of kids where I'm using the principles of intervention, those motor principles of learning with 2-year-olds. So like I said, I'm not necessarily a major expert on it. I kind of just did some, general research to do this presentation. But in my experience, I'm going to start kind of using those motor principles and assuming childhood apraxia speech around about 2 years of age. So yeah, that is the end of my presentation. Here are my references. Like I said, it's all online. So I didn't go read a bunch of research articles. I just kind of looked at ASHA's practice portal, and then Edith Strand is the name of the speech therapist that was in those videos, and she is kind of the expert on apraxia here in the US. And then those videos are linked down below too, so you can watch the whole things if you'd like. Are there any other questions? No. Okay.
I don't see any. Paige, thank you so much for sharing with us that information. It was a great, just great information. And the kids were just so cute on the videos.
Yeah.
So, okay.
Well, I hope I didn't go over time too much. I don't know how much time you guys have, but I have a crying baby in the other room that I got to get to. So
that's okay. We are going to do breakout groups right now. So remember, we'll be thinking about a kid that you're struggling with, or you just want some further information about. This is a great time to utilize other colleagues in the field, other professionals, to get new ideas on that. Before you go, Paige, there is one question that just popped up, and it says, in early intervention, what frequency of visits do you recommend for these kids?
Yeah, so I mean, depending on how severe it is, right, that's gonna kind of dictate it. And I know in my case, in even working for primary children's and working for up to 3, kind of finding the time to fit those kids into the schedule is often like the harder part. But I would say, if possible, weekly visits would be great. I mean, in some of the things that I looked at, they're recommending like 2 or 3 times a week, which I know in a lot of cases is just not possible. So, even if you typically do monthly visits, I feel like increasing it to 2 visits a month and really giving a lot of good parent coaching and giving them like word lists to kind of help them figure out what words are going to help their child be able to functionally communicate better. And that is another thing that I didn't mention, but I know a lot of times people, when they treat apraxia, will come up with a word list of what words are going to be important for this child to communicate what they want, and really target getting intelligibility for those specific sounds. So kind of giving that parent some tools to help make language more functional and to help them understand how to better support that visual cueing. You might be able to get away with making progress without having to do the intensity that you would, typically really want to do, more direct intervention. But yeah, so I would say that's going to, depend on your ability to meet those needs. But if you could do weekly, that would be great. So yeah.
Great. Thank you so much, Paige. All right. Bailey,
Okay.
go ahead and put us in breakout groups. And I know it's easy to just want to jump off, but this is a great time to utilize everybody's brains and information about for kids and different things.
The rooms have been open, so you should have something pop up to join.
Okay, thank you guys. Bye.
Thanks, Paige. Am I supposed to do something?
No,
Okay,
I didn't. Do you want to join a group?
no, I'm okay.
Okay. It didn't have, and I always